All right, good evening, everyone. We want to thank you very much for being here. Everybody, it looks like, has gotten a seat. Hopefully we'll get a few more folks in as well. My name is Cynthia Klein. I am a Principal Associate and Senior Member at APT Associates here in Atlanta. On behalf of APT, we just wanted to thank you very much for taking time out of your schedules to be here for what we know will be, a really robust discussion with our panelists, but also with you guys as well. This symposium has been in the works for several months, and really the idea comes out of this idea that from time to time what we need to do is take a step back away from our desks, take a step back away from our laptops, and really it's to our benefit to be able to get a fresh perspective, get some new ideas, get some new ways of thinking about things, and really new ways to address the challenges, the common challenges that we all face in our work every day. Our motto at APT is bold thinkers driving real world change. And so we hold panel discussions like this from time to time. And this evening's focus is really around chronic disease. And so we are answering the question, innovation for change, what will it take to prevent chronic disease? What we're hoping that you guys get out of this at the end of this session is, maybe first of all, a greater network of people with which to try and solve some of these problems. But also some new ideas, or at the very least, a new perspective on how maybe you can address some of these challenges. With that, I would like to introduce our moderator, who is Dr. Diana Silimperi. She said not to say too many words, but I do have a few. Dr. Silimperi is a senior vice president of global health at APT Associates. She is a public health pediatrician and epidemiologist by training. A little known fact is that she was actually an EIS officer at CDC at one point in her career. She has over 30 years of global experience in the planning, design, and implementation of programs in areas such as maternal and child health, infectious disease, and also non-communicable diseases or chronic diseases. She has worked with both the public and the private sectors on actions that range from community-based interventions to hospital care. And she will very aptly serve us as the moderator today. Thank you so much, Diana.
Thank you, Cynthia. Far too many words, but I appreciate them. You can't do much with my name, right? That's just long unto itself. But to my esteemed panelists, and also to you in the audience, it does give me great pleasure to welcome you. What I'm confident will not just be rigorous, but will be scintillating and significant exchange regarding innovation for change and the prevention of chronic diseases. We'll be discussing, our panelists, some of the major challenges that they as experts have faced in the prevention of chronic diseases, but also explore new innovations. And remember that innovations are not simply interventions, new interventions. They can be new processes, new service delivery methods, new policies, right? So that broader array of innovation is all okay today. Let me share just a few facts to put everything in context. Chronic diseases, as you all know, are a serious and growing problem that have not yet received the attention nor the investment that they need. Chronic diseases kill 41 million people each year, and about a quarter of them are under the age of 70. They also cause disability to millions more, resulting in both economic loss to families and to countries. The key chronic diseases, as you likely know, are cardiovascular diseases, diabetes, cancer, and chronic respiratory diseases. However, obesity is a growing chronic disease which is affecting all ages, including children, across the globe and across the spectrum of low to high income countries. Also of note, in the last year, the World Health Organization has formally added or included mental health under the umbrella of chronic diseases. Low and middle income countries currently bear a significant share of premature deaths from chronic diseases. Not everyone recognizes this. The chronic diseases are not only issues in higher income countries. Yet, only 1% of global funding actually goes to prevent and or treat chronic diseases in these low and middle income countries. Turning to the US, and as I say this, look around the room at each other, because 6 in 10 adults in the US have at least one chronic disease, and 4 in 10 have 2 or more. So look around you and count to 10. Chronic diseases, present company excluded. Chronic diseases are also the leading cause of death and disability in the US, and the leading driver of the $3.3 trillion annual cost of our health care. The risk factors for chronic disease are all in unison: lifestyle, right? So tobacco use, poor nutrition, lack of physical activity, and excessive alcohol use, just the main ones. All of them are linked also with social determinants of health, as you can well understand. So part of the challenge in tackling this problem, and we're going to hear more about it from our experts, is in fact that health financing and health resourcing has not been sufficient. Chronic disease care, be it preventive, diagnostic, or treatment, is not well integrated into primary health care platforms, globally, or frankly, even in the US, although we're improving. Nor are they included in essential health packages of care that ministries of health around the world, or networks of healthcare in the US, commonly deliver. So health insurance and third-party payers do not typically cover the spectrum of chronic disease care or the providers, especially at the community base, that are so important to deliver lifestyle interventions. In 2017, a global burden of disease study was published in The Lancet, stated that most of the nations out of 195 countries would fail to meet the Sustainable Development Goal to reduce deaths from chronic diseases by 2030. And horrifyingly, they also found there was less than a 5% chance of any country eliminating childhood overweight or obesity in the first 2 to 4 years of life. That's appalling when you think of the ramifications of that statement. It urged a whole of society approach was urgently needed to address chronic diseases. I think with that in mind, we're going to turn to our panel, and I will introduce them a little bit only because they have very nice longer profiles in your programs, but all of them are experts in the field. I'm going to start, and as I say your name, would you just kind of nod or wave? Start to my far left with Maria Boyle. She is a senior associate in APP's Division of Social and Economic Policy with more than 20 years of experience on programs, research studies, and evaluations related to nutrition, access to healthy foods and physical activity, obesity prevention, and federal food assistance. Next to her is Matthew Darling. I really want that name instead of Silimperi. Matthew Darling is a vice president at Ideas 42, where he's contributed to projects on poverty, healthcare, and early childhood education, among others, and is also a teaching fellow in economic design at Harvard. His work has focused on increasing adherence to treatment and applying behavioral science methods to social problems. Christie Joseph is next, and she is a public health advisor at the Center for Global Health and the Center for Disease Control and Prevention, where she's also a team leader and providing technical assistance on a really important global hearts initiative in low and middle income countries with support from Resolve to Save Lives in Vital Strategies. And next to me here is Debbie Kibbe, a senior research associate at the Georgia Health Policy Center, with, again, over 2 decades of exploring how to prevent and manage childhood obesity. So at this table, we have multiple decades, like a century of experience here to share with you today. And so welcome to you all. The format for this session is going to be opening statements by each of our experts, followed by a series of questions with a lot more free-flowing in that second. We'll let them each have sort of some key things they want to share. Then we'll have a free-flowing discussion, and they'll conclude with a few take-home messages that hopefully will be meaningful to you when you leave this room and go back to your respective positions. I'm going to ask you to kindly hold your questions until after the free flow so that we can actually finish on time. We will be glad to stick around after the session for more in-depth discussion. But I also want to urge you, throughout, be writing down questions that you want to ask, but also be writing down your own thoughts, because across these set of tables, I know we have a lot of experience. And so you may want to add some of your recommendations or some of the innovations you've seen work. So when we go into that last kind of Q&A session, please share then what are your thoughts, your recommendations, or your experiences as well. All right, that's our flow and that's our panel, so let's get going. And I'm going to start with Matt. Would you please share an overview of your relevant experience and some of the main challenges that you've seen facing CD prevention that require innovation? Yeah, flip it on and wait till it goes green.
Hey, can everyone hear this?
Yeah.
Great. So thanks so much for the introduction, both for me and for the other panelists. So just to give a little bit of background, as she mentioned, Ideas 42 is a behavioral economics research and design firm. And what that means basically is really taking a lot of the insights and ideas and developments that have been happening in the broader social sciences, economics, psychology, anthropology, and saying, hey, people are really, really weird, and we should start using that knowledge in how we design programs and how we design systems. And that really matters, as we mentioned earlier, that lifestyle change is a huge component for chronic diseases, and thinking about the way that we sort of interface with the world around us, really, the cognitive biases come out very clearly. And I think this is something that I think everyone can really hear with sort of a bit of introspection, saying, hey, I have really great intentions for how often I'm going to go to the gym. I have really great ideas for how I'm going to be eating over the next couple of months. And we often just don't find that we live to them. And I think one of the things that's really important when you come out of this is saying, okay, we understand that things like our willpower are finite. We understand that our ability to pay attention to all the calorie counters and stuff like that is finite. And then saying, okay, given these constraints, given this stuff that we know about the world and we know about ourselves, how can we actually design systems and programs that make that work better? So I've done a couple different projects on that, some of the work that we've been doing with app, but I'll talk about some stuff we've been doing. This is going to be that we've been doing with Robert Wood Johnson, but looking at how you reduce sugar-sweetened beverage use. And this is especially looking at stuff with young kids, where they're basically drinking sodas and stuff like that, and just thinking through that as a very as a default, whether maybe that's 4 or 6 or 7 cups a day. And what's really interesting is you say, okay, why is that? And part of it is things that we know about is things like taste. But the other thing is you can make a lot of other tasty drinks. It just takes a lot more time and a lot of energy, and the other things are right there a lot of the time. And so saying, one of the interventions we designed around that, for example, was just saying, okay, we're going to be setting up a program where we're just going to mail, fruits to you that you can then infuse in one of those nice little Brita pitchers that we bought for everybody. And we're just going to mail those to you, get them in the mail, and you take 30 seconds to fill it up. And it was tremendously effective. And it's kind of interesting because, we could just be doing this. It's very easy to do. But just giving them that little bit of a head start by saying, hey, you're going to be getting this fruit in the mail no matter what. That's all happening for you, actually makes a big difference. So it actually have the amount of sugar-sweetened beverages people were drinking over the course of our study. There's lots of other things I could talk about. I'll wait for questions and stuff like that, but I just want to give a sample project.
I think that's particularly pertinent. I'm sure some of you have seen the announcement today from the American Academy of Pediatrics, American Heart Association, in terms of new recommendations and policy recommendations. I think we'll talk a little more about them, but in terms of reducing the sugar-free beverages and access and marketing to them and so forth. So really important policy coming down, which really picks up. And what you were describing was really the nudge theory, right? I mean, at least a kind of simplified element of that, which I think I love that social theory that you've applied so effectively in the context of behavior change. Super. And Debra, how about you? What would you like to share with us?
Good afternoon, everyone. Thank you for braving Atlanta traffic to be here. I appreciate it very much. So this is my 20th year in childhood obesity. I think I consider myself an old thinker, as you said earlier. So let's just review some numbers. 74 million kids in the United States. A third of them are overweight or obese. 12 million of them are obese, compared to 6.1 million children who are diagnosed with ADHD or 6.2 million who are diagnosed with asthma. No other condition affects so many children as childhood obesity and overweight. In the state of Georgia, we assess annually 1.1 million children for fitness. 1.1 million children. We have body mass index data measured, aerobic capacity data. And what we know is our girls are very unfit and very overweight. After working in schools and healthcare systems and faith communities and community-based work, WIC, SNAP, early childhood centers, some of you in the room I've worked with in early childhood, we have a lot of systems touching our children's lives. And I believe that we have to do better at those multi-setting, multi-system interventions that last more than a year or 2 years or 3 years. We are not going to get our heaviest children back to a healthy weight with 1 year of funding. So I believe in order to innovate around chronic disease prevention, we need committed funders who will fund for the long term, multi-sectoral, multi-partner, multi-funding, so that we can get to true change. One example in the state of Georgia is very soon, I believe there will be an announcement that 5 years of investment will be made in getting middle school girls more active. 5 years. Physical education, physical activity, for those of you that are familiar, the CSPAT model, the physical activity framework that came out of a panel that I was part of. And so I believe that as we think about chronic disease innovation, that we're going to have to be realistic about how we invest, who invests, how long we invest, and what we invest in. And the last thing I'll share, I was at Emory University yesterday teaching a class on childhood obesity, and I had them read an article. 42,000 citations were reviewed. 139 studies met the criteria for inclusion, and 115 of those were in schools. We have many gaps to fill and much innovation to partake on as we consider how we're going to reduce chronic diseases. Thank you.
Thank you, excellent. Do you have any knowledge of how many other states are looking at Georgia and what you're doing there, and if there's any cross-learning going on between states?
So Georgia is considered the gold standard for fitness assessment in the nation. We have shared our protocols for training, implementation, and tracking. We map the data, and many of you who are familiar with the Health Policy Center know that we have a legislative health policy certificate program. That data is not only shared with the legislators annually, but it is also shared back out to the schools. We want those physical educators who are assessing 700 children in the course of a week to know that we're using their data. And so there are about 4 other states that are doing statewide fitness assessment: Texas, Missouri, Delaware, and the other one's out of my brain. But the other model that I'll talk about a little bit later that's statewide is called Power Up, and so that's another example. Thank you.
Great. And over to you. Yeah, Maria. Yes, you may, please.
Can I ask a question?
Of course.
Okay, good. So I was really curious about this potential investment, and is that coming from the Georgia State Legislature or private foundation? Okay. And then will you be using, in terms of evaluating it, will it be using the same data that's been gathered every year, and that's going to be, okay.
The outcome is more girls in the Healthy Fitness Zone for aerobic capacity.
Okay. And it'll be done through the schools and... as far as you know, in and out of school. Okay.
Good, good.
Okay.
You know, I
Great.
just can't help reflecting. like a century ago, when I was in grade school, I remember that we started at that time there was a program that probably only one or two of you in the room may remember, but it was called Go That Chicken Fat Go. And you did exercises in school to music. So that's how long we've been saying our kids are out of shape and need more exercise. So let's do it this time, this century. Let's just do it. And when we come back and go into other discussions, I think you can add some of those other excellent points. Maria, I know you've got a really important experience to share, and love your perspective as well on this.
Okay, great. All right. Well, hi everyone. I'm thrilled to be here today. I came down this morning from Massachusetts. It was a lot colder, so I'm happy to be in warmer weather. So that's always a nice part of traveling south for me. So my experience, I've been at APP for about 6 years, and I work with our nutrition group. My background's in nutrition, and we look at a number of national studies that are basically looking at nutrition policy implementation. So, for example, we just finished a study looking at the 2010 implementation of the 2010 meal standards for school meals, and looking at effects on plate waste, the costs and revenues of producing meals with these new meal standards, as well as dietary intake. We're currently working on a study of childcare sites, family daycare homes, childcare centers, Head Start programs, as well as after-school programs, looking at wellness environments, again, meals and snacks, costs and revenues of providing those meals and snacks, and also looking at policies and practices within all of those different childcare settings. And I also I work on another study that's specifically focused on reducing early childhood obesity. And it's evaluating 15 different interventions that's more local. It's based in Los Angeles County. And we're doing a collective impact evaluation of about 15 different interventions that range from hospital breastfeeding policies to creating parks to nutrition education, and they were implemented at different points in time, and obviously have different focuses. So we've been doing a combination of sort of qualitative and quantitative evaluation. We've done stakeholder interviews, focus groups. We've done GIS mapping to kind of get a sense of the reach of all of these interventions, and then we've also looked at WIC data, CHIS data, Kaiser data to get BMI, as well as a whole series of outcomes that we've been looking at as well. And, as for this last study, as we've been we're almost at the end of it and we're finishing up. And, when I look at the results of the study, to kind of see what the collective impact of all these different interventions has been, because it's kind of an innovative way of evaluating an initiative, is looking at the kind of the impacts across all these interventions collectively. I see that where some of the outcomes that we're looking at are going in the right direction, there is very little significant findings in terms of impacts on physical activity, walking, vegetable consumption. And while some of those, like I said, are going in the right direction, we are decreasing fruit, we're decreasing fruit juice consumption, increasing fruit consumption. Some of the others are not really showing any kind of movement in the right direction, let alone any significant results. So my challenge as an evaluator and as someone that does a lot of research studies is, how do we say, okay, these interventions, this initiative is moving us in the right direction in terms of chronic disease prevention or in having some kind of impact on chronic disease? Because I know that, we have a couple of small impacts, but is that enough? So that's, I think, where my struggle comes in as an evaluator. What is, do I have to have clear results in all these different outcomes, or is one enough, two, or kind of what is sort of the number of outcomes I need to see to feel like the whole community is being pushed in the direction of preventing or addressing chronic disease?
Thanks. I think we're going to come back to that in a minute. And Matt may begin to address some of this issue of individual behavior change, community, norms and so forth. So we'll pick up on that again. Let me just ask you a quick question. Are you also, are you seeing any differences by gender? Because that's something we've noticed internationally, that some of our chronic disease programs have varied in terms of impact based on the gender.
Right. So we are, I don't have the numbers in my head, I kind of just have the overall, but basically, we're looking at impacts on families that have young children from ages 5 and under. So I think I'd have to go back and look, but I don't think we looked at specific gender differences. So we're looking at BMI for the young children, and then kind of things like walking and physical activity for the adults and at the family level. So
might be something to think about even at that young age.
Yeah,
I think the differences may go
You're right.
back earlier.
Yeah.
Reformed pediatrician, I've got to bring.
Yeah, I didn't realize it was a pediatrician. Okay, that's good to know.
All right, thank you very much for that. And last but not least, Kristy, I'd love you to share your thoughts, and I know you've been working internationally as well, and also in the area of cardiovascular disease, I believe. So over to you.
That's right. Thanks everyone for being here and listening to this panel. My name is Christie.
A little closer to the. Sure. There you go. Is it on? Okay.
My name is Christie Joseph. I work in the Global Non-Communicable Diseases branch in CDC. It's in the Center for Global Health. And in our branch, we focus on 4 main areas, which also aligns to the challenges with global chronic diseases as well. And our areas of focus is predominantly on surveillance, monitoring and evaluation, so using innovative technologies to collect NCD risk factor data, generating the evidence on chronic disease management and policies through economic studies and analyses, program design and capacity building. And this is where we have the Global Hearts Initiative. That's where this was kind of formed and developed with WHO, PAHO, and a lot of other professional organizations to have a strategic approach to reduce chronic cardiovascular diseases through a set of technical packages, which I could talk about later on the panel, one of which is called the Hearts Technical Package, improving the care and service delivery of hypertension at the primary healthcare level. And our last area is partnerships, both internally in CDC and externally. Internally, we work closely with our chronic disease partners that work domestically. So instead of reinventing the wheel, what has already been established here domestically and can be adapted and adopted for a global setting. And then externally, we completely depend on all of our partners, not only WHO and its regional affiliates, but also professional organization, academia, and NGOs like Resolve to Save Lives. It's a strategy, it's a partner of Vital Strategies. And Resolve to Save Lives started in 2017, and it's led by former CDC Director Tom Frieden. There's a 2-pronged approach to what they do. One is on emergencies and preparedness, and where we work within our branch is on the Cardiovascular Health Initiative. There's 3 areas in the Cardiovascular Health Initiative. One for hypertension management at the primary healthcare level, so increasing hypertension control by 30% over 5 years, reducing sodium consumption by 15%, and eliminating artificial trans fats from the food sources globally. So we work with Resolve to Save Lives across those 3 areas through surveillance, monitoring and evaluation, economics, and also capacity building.
Kristy, I'm wondering if any of the data that you're looking at, although it's in the area of cardiovascular diseases, to come back to your question, Maria, in terms of what's impact, some of it could be looked at in terms of return on investment. Right? And so the economic data that you're gathering, I think, is really important when we start to look at really which package, what's enough. Do you want to?
Yeah, and that's important. The economics piece is extremely important, not only for countries to advocate, to implement these programs, because similar to what's happening in the United States, chronic diseases if they have any money, it's a lot. I mean, there's no money or support or acknowledgement for chronic diseases in many countries. And only recently have they established an NCD unit within the ministries of health. And we see that this is a big problem in terms of capacity. We have a program called the Field Epidemiology Training Program. It's similar to the EIS program here in the States. And we're focusing on building the capacity of epidemiologists on chronic diseases, right now on just hypertension. But because it's a difficult one to do, because a lot of folks that are working in the ministries of health, they are coming from HIV or malaria, and they don't have a background of NCDs. And NCDs is extremely different from infectious disease, as you all can appreciate. And having that understanding of not only data sources, data use, but also how to partner not only with other ministries, the Ministry of Finance, Ministry of Education, the Ministry of Justice, to improve cardiovascular diseases in their countries. It's a big challenge, and there is not a lot of support or capacity with that. So with Resolve to Save Lives, with that backing, I think that can help us collectively do more faster.
I'm hoping that also am I echoing back there? I am. Maybe we can ask them to turn it down a little bit. Sorry, I don't want to reverberate off the back wall there. But I'm hoping that there's also a bi-directional exchange going on what you described. So we're, of course, learning from what we're doing here in the U.S. Yeah, I can do that. We can learn from what we're doing in the U.S. and transfer it overseas, but also they can, there are things going on overseas, albeit less, but that could come back here. And I'm thinking particularly on the issue, and we'll come back to this as well, but again, we talk about reaching families and communities and that link between families and communities, particularly for prevention and the health system. Those community-based frontline health workers are absolutely critical in that. And you're absolutely right as well, though, so that we can learn from overseas, frankly, and apply here. But then as you go up through the spectrum of the service delivery system, and this is an issue in the U.S. as well, as I alluded to, we really haven't integrated chronic disease care within primary healthcare systems by and large. Nor do the providers, are they trained in that area? So when we talk about innovation, we can also look at innovative training, innovative system changes as well. Let me just, before we move into that next question, let me just see if any of you wanted to add anything to what your compatriots have said. Go ahead.
I thought Kristy's point about, having to move from working in malaria or HIV to chronic diseases, that's such an interesting sort of transition you have to make. Not only from the sort of obvious points of what kind of expertise you have, but how do you actually go and tell people what to do and how you should frame that to them? There's really with a communicable disease or there's sort of very specific things you can say, okay, this is how you should be thinking about sex partners. This is how you should be thinking about exposure to the environment. And then you say, okay, instead of looking for these, clear, salient risks and being aware of them and trying to use that, now that you're just in this miasma of bad health choices all the time, which is such a different sort of frame you have to have in place.
Let me just say one thought, and then back to you, Kristy. So, as she was speaking, I was thinking of you, Matt, as well, because although we were looking at the nudge theory in different ways, there are all these behavior changes across the provider spectrum and the service delivery system that also could be nudged in different ways. So, Kristy.
A program managers training in Rwanda in 2016, and this was to kind of educate them because they all came from a background. And there was a request from Rwanda, the Rwanda Biomedical Center, which implemented chronic disease interventions in that country. And what we learned from them, even though they had different backgrounds than NCDs, their approach to NCDs was not necessarily population level or policy level. It was very much at the healthcare level, because that's what they learned from HIV or malaria. And so it was a completely different approach. And also the idea of industry, especially in these developing countries, industry is coming in, building a schoolhouse and plastering an advertisement, and also reducing the cost of sugary beverages or tobacco or alcohol. I mean, they are very, very savvy, and I think that's something that we were trying to explain to them, that, you can get ahead of it by working with your leaderships, not only who is above you, but also below you. So working both levels to kind of get this understanding of how to combat NCDs. And in these countries, it's really difficult because infectious disease, it's obvious, right? More obvious than chronic disease, why we have to work against it. It's not so obvious. So what we were saying, and we had a consultant from, he's now retired, but he was the lead of NCDs in the Department of California in the 90s, late 80s and the early 90s. And he was saying, find somebody in the Ministry of Health that has had a heart attack, or had her mother or father had breast cancer. You can get them to understand that you can help this, you can prevent this, and this doesn't have to happen in your country.
There's a lot of what you just shared that I think we're going to pick up on in a number of our panelist discussions as we go forward. Maria, and then I want to turn it over to Matt.
Just waiting for the green. Kristy, I just had a kind of a comment and a little bit of a question. So I did a little work in India recently where around nutrition, where we were looking at different nutrition interventions. And so, there's fortification that has just recently gone into effect in India where, some of it's not completely mandated, but it's partially mandated. And so some of the things that are being mandated are like vitamin A and oil, and they're doing double fortified salt that includes iron and salt. So while these kind of, micronutrient deficiencies still exist, a country like India is also struggling with chronic disease. So how do governments and NGOs and kind of public health get that message out? Okay, for some of you, we want to encourage you to have salt and oil, but for others, you shouldn't have that at all, right? So I think it's a real, I know there's no answer yet, but I think it's part of the whole, it'll be interesting to see kind of what messages India comes out of that, and sort of how that can be applied more globally, I think.
Yeah. See, we're gonna come back to you, okay? Very important points. We'll come back. But Matt, we were talking earlier about your experience with behavior change and the nudge theory and so forth. So I'd like you to pick up on that and perhaps share with us what you think we can all do to increase demand for sound preventive interventions.
Sure. And just so when we talk about nudge theory, we're talking about some stuff that came out of the behavioral economics world. So there's a book called Nudge by Cass Sunstein and Richard Thaler, which is basically saying hey, we have a whole bunch of policy tools that we aren't really using that are about sort of not trying to use incentives, not trying to do anything like that, but trying to say, hey, can we just give people slight little changes that actually have big effects on behavior? So, going to your question, I think, one thing I'd start doing is just reframing it a little bit, because we say, okay, we want there to be more demand for these programs. And we can mean that by, two different ways, like demand for it from program participants. We could also mean almost, and this is my economist coming in, almost supply. We want government programs that are funding these things. We want people, to be supporting them. So I'm gonna tackle that, both of those separately. So first, I'll say, when we talk about participants, is there demand for programs? And I think what you see a lot in the world is there's a great program that's been, tested, that should work, that has been proven to work. And then you say, okay, we're announcing this, we're going to be running this in this state, and no one comes. And you say, aha, there's no demand for it. And I think one thing that comes out of the behavioral science work is that that's not necessarily the case. That, I know that there's things that I really want to do, there's courses I want to take, there's things I want to do for my health that I just don't do, not because I don't want to do them, because I'm always doing it next week. It's always something that is a little bit beyond the horizon. And so I think, one thing is just making sure, okay, is this an actual demand issue? Is this something where people don't want to do it, or they don't know that that the program exists, or is it something where we are making it hard for them to participate? We're making it difficult. We're not running the program at the right hours or in the right place in a way that makes it very hard for them to actually interact with it. And so, I think looking for those sorts of opportunities, how we can reduce hassles, I think that's incredibly important. The other point is how can we sort of increase demand from policymakers? How can we say, hey, how do we get people to be excited about these programs and want to run them? And I think all of us try to answer this question every day in a lot of different ways. I'll say, it's always important to show that stuff works, that you can go and have evidence-based approaches and they're effective and you can scale them and you can transport them to other areas. I also think it's important to think about how you can be solving specific problems for other people, whether that's governments or foundations or anything like that. And I think one of the tricky things about chronic disease especially is because everything's so holistic, everything is tied to poverty, everything's tied to social structure and how, agribusiness and transportation, we can sometimes say, well, this is a really, really huge problem and we can't make a dent in it. And I think trying to figure out, okay, where are the dents that we can make? And not, any given dent might not be enough to solve it, but a lot of dents can really, malform it in a couple different ways.
Okay, thank you. Debbie, you've had some experience in Georgia that might also lend itself to answering this.
So, Matt said something earlier that triggered what I often, when I'm presenting or talking with folks, this idea of the prevention gap. We all know, but we don't do, right? If I asked you to raise your hand, how many of you know you're supposed to be eating 5 to 9 servings of fruits and vegetables a day? 100% of you would raise your hand. And then I'd ask you to close your eyes and say, how many of you do it? And we might get 25. Well, in this room, probably 100%. But my point is that we've been doing all of the community health needs assessments. Many of you know the IRS requires nonprofit health systems. So we've done Piedmont and Kaiser and Wellstar and Tanner and Grady. And I cannot begin to tell you how many community residents have said, we need more diabetes programs. We need more hypertension programs. We need more fill in the blank. And they're already there. And so I think Matt's point about reducing the hassles, right? In rural West Georgia, if they don't have transportation, right? If it's not offered with food, right? These are things that we know cause people to come and to stay, right? The attrition rates are often very high. The other thing I think we don't do well is assess the readiness of people to come and stay in an intervention. If we're not ready to commit to DPP, which is a year-long program, let's send them to something that is more realistic, that's 6 weeks long, right? So I do think we have to be realistic. There is a knowing and doing gap. I think there are programs out there, but like you said, we have to reduce the hassles, but I also think we have to be realistic for the people who we're trying to serve and say, what's going to get you there? How can we support you in staying there? And how can we support you when the program is done?
Another element of that support, and I'd like to see if any of the panelists want to add to this, is not just to support the individual, but to look at a support base from the family or from the community. Take it.
Just triggered that this is one of the primary barriers to getting folks there that we heard from the community is my doctor didn't refer me. Right? Often clinicians are talking with the patient about how they should manage their disease versus helping see them as a self-manager and empowering them around the different decisions they could make, one of which might be a referral to an evidence-based program. So one of the things I do think we have to do better is work with our clinicians to make sure they're treating patients like knowledgeable self-managers of their condition and help them find a solution that works for them.
And again, not just the individual, but maybe their family or a larger cluster to do that. I'm going to actually, Maria, jump a little bit back to this issue of evaluation again, because I think it is important in this context.
Okay.
Take it. It's okay. Go for it.
Great. Yeah, and I think, again, I think we need to think about the kinds of outcomes that we are looking at and that we are measuring when we're doing these kinds of programs and doing these kinds of interventions, and what are sort of some short and intermediate outcomes that we can kind of say, again, are going to lead us in that direction of addressing chronic disease or chronic disease prevention. I think, we as a field need to kind of come to some sort of agreement of, how we can do evaluation that is sort of shorter term programs without doing these kind of large 10, 20-year evaluations that are completely unaffordable. Donors and funders are not going to fund those, even though they might like to see outcomes such as BMI, changes in diabetes, changes in blood pressure, those kinds of things that are all tied to chronic disease. What are some short-term and intermediate-term outcomes that can actually be measures that'll lead us in that direction? And again, I am actually really hoping that during the Q&A, you all will have the answers, and then I can take that back. But I think it is an interesting point, and I think I would be interested in seeing that sort of developed in some way, and that we, like I said, as a field would see if this is in place and this is in place, maybe a policy is passed and it's implemented, and that's enough to sustain an environmental change. And we know that down the road, in 10 years, that is going to have an impact on childhood obesity. But, getting to that point in an intervention where a policy is implemented, that we can say, okay, that's good enough for right now. And we know that we're going to see that change down the road. So
I know we're going to come back. Hopefully we'll have time to talk about some of the research gaps. But it seems to me that one really important one, and that's why I was picking up on what you were saying, Debbie, is this issue of how do you measure empowerment at the individual level, at the community level? How do we do that? And how does it have some rigor when we say we're doing that? And again, has influence in terms of continuing with a particular program or not, and so forth. But I think that's really critical in the area of chronic disease. Matt, you look like you want to jump in, and Kristy, I'm going to come back to you, so be prepared.
I'll just say, I definitely don't know if we have a metric for that sort of engagement and everything like that, except actually seeing what happens. But I was thinking about this when Debra mentioned that sort of readiness to commit issue, and I think that's right in terms of figuring out when they're ready. But I also think it's important to sort of think about readiness to commit or those things as being variables that we can change too, and saying how can we build that ability and build that, interest in committing and get people, not just saying, aha, you're not ready to commit, you're not at the right point right now, we'll come back to you later, but saying, okay, what can we do to get you there? What can we do to help build that sense of self-efficacy? Or what can we do to sort of get the program to meet you where you are? I think one of the things I find in my life that's really effective is not go and say hey, I want to run faster, I'm going to go run 5 miles tomorrow. But say okay, I'm going to jog a little bit to the bus stop or something like that. Trying to find those very, very small changes. Because I think people get intimidated. They hear, I know my mom was told recently she had to lose 50 pounds, or that's what she heard. I feel like she's probably told to lose 15. But she came back and she was oh yeah, they told me I'm at risk of diabetes. And I'm oh, I actually studied this a little bit. But it was just really intimidating to her to hear that, and I'm thinking oh yeah, but these sorts of smaller changes you can make might be more approachable, or you can try and build that sense of self-efficacy.
Excellent. I wanted to come back to Kristy because you actually in your previous response started to go in this direction. It's an important one. I didn't want to cut you off, but you were talking about the multi-pronged approach, if you will, and I want to pick up on that context from the report in the Lancet about the whole of society approach. And so with your experience internationally as well as in the U.S., how do you think we can begin to integrate some of these concepts into prevention program planning, including role of industry that you alluded to, and I know other folks have some experience on that. And now again, I think in all of our minds, the policy that came out today or the recommendations for policy from the AAP and the HA. So what are your thoughts on that, Kristy? A nice small question for you.
Yeah, I mean, it is a whole of society approach for NCDs, and it can't be done in one sector. And there is a need and a demand to work with industry, and that's hard to do because they have their own self-interest to sell their products. And so a part of Resolve to Save Lives, there's a technical package from WHO called Replace. There's a lot of technical packages out there, and essentially what a technical package is a set of evidence-based interventions when combined have a synergistic and high impact outcome on the disease area. So there are technical packages for tobacco use called Empower, that's been around for many years now, for sodium reduction called SHAKE, for physical activity called Active, and artificial trans fat elimination called Replace. And one of the modules of Replace is to work with industries to replace artificial trans fats with healthier oils. And this is being done globally, but mainly, it's being done in a select number of countries. In Thailand recently, just had a policy passed in January of 2019 to eliminate artificial trans fats from their whole food source. India had some voluntary regulations late last year. Chile has a lot of really good nutritional labeling, and they are on that road for artificial trans fats elimination. Also, working with industry, on the flip side, beyond kind of like a policy approach for food sources, for hypertension, it's a huge issue of availability of medicines. Even if they are available at the country level, they might not be affordable or accessible. There's a lot of issues on even medicines being on the essential medicines list at the country level. I think about 60% have the core hypertension medicines on their medicines list. And there is an estimate of, I think, about $8, sorry. I think it's about, it costs about 8 working days for a brand medicine and 1 working day for a generic medicine, on average, for the lowest paid worker in that country. And so there's a lot of discrepancies on this. And the thing is that we can not only learn from what we've done in the United States, but what's been done in other disease areas. Immunizations, contraceptions, contraceptive medicines, HIV, TB. There's been coalitions that have been established so that medicines can be accessible and available and affordable in these countries. And it's not being done for hypertension or other chronic diseases. And it's a shame because hypertension, there are medicines that are effective, that are available and off patent. And that can be said for a lot of different medicines.
Yeah, again, part of that is the issue that the chronic diseases are not fully integrated into essential health packages that do have the essential meds and so forth. This is internationally. But I think it does actually influence, as you're saying, even in the U.S., if you look at a breakdown by state or by county. And Debra, you've had some big experience with that, and Matt, you as well, in terms of policy and industry. But let me go to Debbie first.
2 points I'd like to make. I should disclose that for 13 years I was with the International Life Sciences Institute Research Foundation, ILSI. And ILSI is industry, academia, and government coming together to address public health science issues of interest to industry. So when you're talking about fortification of staple foods and condiments, they were at the forefront of fortifying soy sauce and fish sauce in China and Vietnam, and establishing a sodium iron EDTA plant in China. They're responsible for some of the most clean water in some of our developing countries. And I recognize why we vilify industry. And I'm just going to share 2 examples. 1, right now, childhood obesity is losing its sexiness. And I know that mental health, even in our own state, is coming to the forefront, and understandably. But at this point, we need as much investment as possible to get our children, our youth, our young adults healthier. Eating better, being more active, sleeping better, reducing screen time. And charitable investments are going to happen from private industry. I want them to invest in childhood obesity. And if we continue to vilify them, they will not do it. I know that from personal experience. The second thing I'll point out is this, and Heather is in the room, and she was part of the group that established our childhood obesity systems model that is informed by our state data. And when we were creating that model in the mid-2000s, we had legislators, their staffers, and subject matter experts in the room, about 16 people. And we heard loud and clear that sweetened beverages was not a lever that we could include in that model if our legislators were going to support action on childhood obesity. Why? The beverage industry contributes $12 billion to Georgia's economy. Over $1 billion in taxes are being paid. And we wanted our legislators to take action, and so we listened. And as a result of that model, two things happened. The SHAPE Act was passed, which allows us to assess children annually for fitness. Again, 1 million kids. And the second time we presented it, and we told them that $52 million had been invested from public-private partnerships over the last 8 years, and 1% more children were in the healthy fitness zone for BMI, equating to 10,000 kids. They heard us, and they took away the sunset date. I think we'll continue to need to partner with industry. I know they have a role. I know there are certain roles they should not play, but I do think they're a critical partner.
We're certainly seeing that internationally as well, that private sector, both private sector providers, as well as professional associations, but also private sector, corporate and philanthropic private sector, are important contributors in the area of chronic disease. Not to the disease, but to prevention and or treatment. And part of that, frankly, is because the traditional donors have not always stepped up to the table. And so private sector has moved in. One of the issues is, however, they're not usually integrated. First of all, their efforts across different companies are not aligned or coordinated. So they may be doing several things in the same country and not even be aware of it. And so you don't get that leveraged impact because they're not aligned with each other, nor are they necessarily aligned with the country policy, ministries of health, and or global bodies. So I think they really do have an important role. They are already contributing in many countries for training, particularly grassroots providers or frontline workers, and yes, sometimes some products as well, pharmaceuticals, but the fact is they haven't been aligned, and so they haven't had the impact, and then sometimes, again, there's working across purposes. But certainly to reach universal health care, we are not going to get there without incorporating and leveraging private sector providers and beyond, and within that, clearly chronic disease is a really important portion. Maria.
I'm always waiting for that green light. Debra, I was going to ask, given the AAP recommendations that came out this week, related to excise taxes on, recommending excise taxes on sugar-sweetened beverages, kind of that vending machine should emphasize milk and water. Do you think that, Georgia is going to have to come up with some innovative new models, to sort of work with these beverage industries? Do you think that's something that, you would think about developing, or that's something that, I don't know, is going to be needed at all? I think given this sort of, I agree with you about the sort of childhood obesity not being quite as sexy as it was, when I was working on it like 10, 15 years ago. It's really, it's lost its sort of, allure and excitement for people. So I'm just wondering, one, I guess if these new recommendations if you think they'll kind of have sort of some sort of surge in interest, and also will they kind of require the industry to kind of think a little bit more about what they're doing and develop any new models? No, it might be the answer. and that's okay.
Well, my first thought is no from the perspective of our legislators. I'm mindful of our bottom line. But the second thing I will say is, two things. Industry was one of the few groups that met the Healthy People 2010 objectives. They created food products and beverages that were friendly for those with diabetes and hypertension. And so when they're charged with something, they will work. And if any of you know Ilse, you know that a former executive from Coca-Cola was one of the founders of it. And they made a commitment more than 10 years ago that 90% of the new beverages they were going to put onto the market would be low or no calorie. Coffee is the largest product that Coca-Cola sells. There's a lot of Chinese and Japanese adults that are consuming coffee, right? And so, but I think that's a lie. Because when I see the ads, all of you have seen the ads here for the new vanilla orange cream. It's not a low calorie, no calorie. Well, maybe that's the 10% of the 90 plus 10, right? But I do think they worked for a while when obesity was at the forefront. And maybe now that it's not, they're shifting back. And I think we need to apply pressure to make sure they don't do that.
So what I'm really hearing is that we need to work at the community level, get the data and the knowledge, information back to the community members and empower them. We also have to work with the system, the delivery system, the health system, and we have to work at the policy level. So we really do have to work simultaneously at multiple levels in order to move this forward. Matt, I want to come back to you about that because, this interaction between individual behavior change, particularly for lifestyle changes, or the social determinants of health. So what can the individual do? The norms of the society, that kind of cultural normative influence. And now I'm going to add policy to that as well and say, what does this dynamic mean and how can we take it into account when we're designing prevention programs?
Yeah, I was thinking about that. I was thinking about especially the comments earlier about, childhood obesity isn't sexy anymore. I'm like, I wonder why that is, right? Like what makes childhood obesity of all things either sexy or not sexy? And is it just sort of like, it was, as you said, like really, a new problem people were excited about in the mid-aughts and like then just like, okay, we worked on this for a while, we made some progress but not much, and so we walked away from it just because it's not interesting anymore. Or is there something like deeper going on? I don't have the answer to that, but I was thinking about that whole last conversation. I think when we think about like, okay, how do social norms change? I think they're really, really hard to change. And obviously, like any given norm, like are made of collections of individuals, right? They're made of who you see out in the environment, who you're interacting with, who you sort of define as your cohort, right? Are you saying, are you testing your fitness or what you eat compared to your immediate family? Are you thinking about it, from a broader thing from the rest of your community or what? And I think trying to understand that is really quite important. Some of the work that we've done, not necessarily just on health, but like thinking about how you change that comparison group and saying, are you are you healthier than people that you grew up with? And you can kind of almost always like force the answer to be yes, right? You can always kind of think of a domain of health that you're better at. But at the same time, if you start saying, okay, like who are the healthy people I know, and like what is someone who's just a little bit healthier than me, and how can I sort of think about that? I think that could be something that's quite powerful.
So I'm going to come back, Kristy. Then I see your hand. But I want to just first of all commend you all. You're still really with us, and you're not like ritching around. So I'm going to have Kristy respond. Then we're going to open it up for some questions and your thoughts, and we'll come back then to the panel with your kind of final, summary thoughts or your takeaways. But I think we have a lot of folks in the room that undoubtedly, I've seen some folks scribbling, have some things to add and share and comment on. So Kristy, and then we'll open it up. And I'm going to actually open it up with a question to you all and the panel.
I was just thinking when Matt was talking about social norm change, I think we saw a really good example of this in New York City with tobacco use. Right? They had a lot of policies to reduce tobacco, and it just seemed like overnight there wasn't any smoking in buildings or close to buildings, parks, restaurants, and so it's possible to have these social norm changes, and these things can occur over time. And the tobacco industry had such a stronghold. and they don't anymore. So it's really amazing, not necessarily in Georgia, but in other states and cities, you can see that. And this is similar occurring in other developing countries where taxation and policies to reduce smoke or the use of tobacco is occurring globally. Though it's still a big problem, and it's considered an epidemic in some countries like China, but it's feasible. It just takes time and effort and energy.
Back to that fact early on that you brought up, Debbie, I mean, time. You can't always get the result in 1 year when we're looking at these issues. But, yeah, luxury taxes and these different forms have really played a significant role in Latin America and parts of Asia in particular. So there are definitely lessons there. The question I want to ask you all and the audience, I want to come back to this issue of lifestyle and behavior change and the important nexus between individuals and families, communities, and the health system. And we've learned there's enough research out there and programmatic as well, experience and evaluations that show how important two things are. One is that community-based, whatever the label we give them, the community-based health worker. And there's various permutations in this country. We're even starting to have some community health workers at that level. Community health paramedics, for example, as well. In the U.S. and overseas, there's a broader, more robust, and very many different labels, but community health workers, ASHAs in India, and different types, right? Promotores, a whole variety. But the issue is some of them are formally integrated, like in Rwanda and Ethiopia, into the health system. Others are not. They're extenders or augmented, but they're there. So, by and large, although we have some evidence, largely from smaller projects, that these folks do make a difference in improving not only the identification, but then actually meeting targets for hypertension, for example, and glucose maintenance in diabetics. Yet, what is that when we look at taking it to scale? What's the role of these community health workers, whatever they're called, and the community, specifically, again, around sustainable empowerment that leads to normative change. So again, you really get these built in and not dependent on a program. So I'm going to see if one or two of the panel members wants to answer some of that. Kristy, you might have some thoughts on it again, but then I really do want to see if there's anybody in this group that has experience or wants to respond to that before we open it up to your thoughts and recommendations.
So we see the role of community health workers extremely important in chronic diseases, and it's really leveraging the experiences from HIV or TB for hypertension. And a lot of countries, especially in the more rural areas, because hypertension or high blood pressure, there's no symptoms, it's a silent killer, people don't believe it. It's something that they just... You're telling me that these two numbers are very high, but I feel okay. So it's a big problem. But the community health workers, not only are they able to educate them, so these people are part of their community. It's either a community leader, somebody they trust, somebody they rely on for other diseases. So they have confidence in what they say. But also in certain countries, they can help them either purchase medication, kind of like a bundling of funds on a monthly basis. An issue with the medication in India, they can only prescribe in certain states hypertension medication 7 days at a time. So the strain of people who are hypertensive to get medication on a weekly basis, even if it's available, it's a struggle. So this is where they can become extremely important, and that creates empowerment and sustainability. Utilizing them not only for are you hypertensive? Are you taking your medication daily? But also lifestyle changes. It needs that constant rigor of change. It's hard for anybody to change your behavior and your lifestyle. Just even changing your diet. I can't do that. How can I ask anybody else doing that? And especially if they rely on certain types of food. Here in the States, we can have any type of food every single day. From anywhere around the world, especially if you live close to Buford Highway. But in certain countries, you have rice every single day in all your meals.
So they are very important in doing that cultural translation, even within a country, right, to that particular village or subgroup as well, both in terms of the trust factor, but also in terms of sort of cultural adaptations in diet or whatever that can be useful. So I think there's probably a lot more that can be said along that, but I do want to give you all a chance to respond. So I'm going to ask, I think we have mics that can float around. And can you hear me now? I'm told I'm working again without, bouncing off the wall. And I'd like you to please be kind enough to say your name and identify if you're with any organization before you either share your thoughts on community health workers and or any other experience you've had. You learned something, are there innovations you've been part of, or questions for the panel? All right, got a hand up front here, yay. Okay. And if you address it to the panel, please say which member, if you will.
Hi, thank you all so much. My name is Suna. I'm currently an MBA student, but interning with Remedy, which is a digital healthcare platform. But how we have incorporated, to bounce off your last point, community health workers is to really, in our business model, to incorporate certified diabetes educators into a digital platform. And I think it kind of ties into what my question was going to be for especially Matt and his research, but also something Debra touched on, and really when it comes to meeting the patients where they're at. And since we are in a very technological-driven world, I'm curious to kind of learn of maybe the biases that still exist within physician and clinical workers, because one of the hardest parts about getting our platform rolled out into the community is physicians don't believe that people in underserved and economically disparaged neighborhoods are actually going to complete the program. And it's a series of, it's like watching YouTube and just letting the videos roll, but really it speaks to, what does blood glucose mean? What do the numbers mean for you? And what happens when you get certain readings? But the question is really like, have we, in terms of delivering care and getting physicians to recommend programs and stuff that, I'll say that Remedy has shown that people will complete this program, and we've shown that they've learned something from it about their diabetes. Like, have we looked at how the medical community is really embracing new, changing, innovative ways to communicate better self-care and education?
Great question. Matt?
Yeah, that is a great question. And I have like 3 different answers that I sort of half wrote down. But I'll say, I think one of the broader things you pointed out is like the way that people often think about folks that are like in poverty, especially, and almost like, oh yeah, they're not going to take this action. They're not going to move forward on it. And what's funny is that you actually have, through Remedy, evidence that that's not true, but that bias on the physician side is still there. And we see this all the time in our work, and there's these, really strong narratives about poverty, about, oh yeah, these people are not, forward thinking, they're not going to be, making an action on plans. And when I hear about that, I'm like, have you ever met a poor person? Like, they're really, like they have huge barriers to them, but they're working really, really hard. They're trying to execute these things, but do have a lot of barriers that are facing them. And, I think, one thing that we have to do as a society is figure out how to combat these narratives in a whole lot of different ways. And, not just with physicians, as you said, but like, I think, society more broadly. The other thing I was thinking about that, in reference to something like is, how do you actually like interact with patients? How do you get physicians and patients to interact in sort of like a positive manner? And I was thinking about this, when we were talking about like people who have hypertension and just like, you're like, I don't know what this means. I don't know what to do about this. This doesn't feel real. And I was almost thinking I was thinking about some of the work that's done to reduce tuberculosis. So they have programs in Pakistan where they basically say, I think it's direct observed something.
Yeah, direct observed.
Where basically they're like, okay, we're going to send someone and he's going to watch you take the drug and make sure that you take it. Because we know that people are, like, once they feel healthy, they're like, oh, I don't need the drug anymore. And, like, there's a way you can look at that and say, like, oh wow, that's so silly that those people are doing that, like they're not thinking this through. And I think what comes out of behavioral science is that everybody is like that. Everybody is constantly making sort of bad choices. Everyone has so much difficulty with making, good, healthy choices, especially in these exact type of situations where it's kind of invisible, where it's kind of hard for you to see what the effects are. And I think, learning for ourselves to be sort of compassionate, to understand those issues, I think that's the first step. I don't know what the second one is.
A little known fact, that DOTS program, direct observed treatment, started in the U.S. in Alaska. So for your next trivia show, remember that. Debbie.
I just, one thing I want to mention is when we work with families, the trusted source is different, right, across populations. And a study we did as part of the Partnerships to Improve Community Health was with African American churches. They trust their pastors, they trust their deacons, and when they received their health data back following blood glucose and hypertension measures, they trusted it was true and correct. And as Kristy nicely said, even though many of the congregants would say, but I can't feel it. I can't feel it. I can't feel diabetes. They trusted the results because their biggest champion in their life, their deacon, their pastor, was championing them. And so I think that, yes, we would love healthcare professionals to trust that people can self-manage and use technology. We know that, I don't know, you would know better than I, you guys. What is it? 86% of people in the United States have smartphone technology or some crazy high number, right? Whatever it is. And I know that when we go to the trusted source, the principal, the pastor, right? A community leader, CHW, they trust them and they'll do it. And so I think we have to get out of that sort of healthcare mentality and into the trusted source.
A whole community approach. Thank you. Another question. We're coming around. Oh, okay, we've got one back there first.
My name is Ike Okoso. I'm from Georgia State University. I'm an epidemiologist and a biostatistician, a professor. But I was going to make some observations so that you can react to it somehow. It is no longer an aberration. There is no information or data with respect to a lot of non-communicable diseases in many parts of the world, particularly in non-developing countries. It is no longer a thinking, or we are no longer thinking about the fact that there's a competition between non-communicable diseases and communicable diseases in this country. It is no longer under discussion that many of these countries are undergoing what we call westernization. It means they are going to have to drink Coke. They are going to have to smoke cigars. And they are going to live in big cities. So the question that I have is that one of the fastest growing industries in many of these countries is this idea of cybernetics and information and computer and the telephone. Do you have I need your thoughts. What do you think about a paradigm shift to come up with a new approach to selling the message? Because most people, when you talk about non-communicable diseases, they don't know what you are talking about. Because there are other competing risks. Malaria is there. Pneumonia is there. And those are the major killers. So I wanted to hear your thoughts.
Do you want to address that to any individual on the panel? Or
not necessarily. I think I just want to have my able student is in there. And I think she knows everything. You want to go?
All right. Is it green? Yeah.
Yeah, so I think using innovative technologies, and especially a lot of low and middle income countries, because they've leapfrogged essentially from nothing to technology, to mobile phones, to even smartphones. So they have computers in their pockets, but they may not have clean water to drink, right? You can see that globally. And one of the things that we do at CDC is collect NCD risk factor data using the mobile phone. This has been done in Morocco, Zambia, Sri Lanka, the Philippines. Thank you, Rachel. Rachel actually works on that project. And you know, the first thing is we need data, right, to see what the problems are and what the issues are. then we can assess what interventions, both programmatically and or the health system or policy level, can be implemented. And from there, you can still use mobile phones to collect data to see how well the interventions are effective or not, and how well people are appreciating that. This has been done before using the tobacco example. Again, globally, there's a global adult tobacco survey, global youth tobacco survey. These are household level surveys, but they collect, how people feel and see the policies that are being implemented through the Empower technical package. But this can be done through all of the chronic diseases and their risk factors. So the platform, the technology is there, and also the area of social media is completely not used a lot. I don't know why public health is kind of behind the curve in terms of technology and what we do with it, but everyone looks at social media. Facebook, Instagram, Snapchat, there's all kinds of things, Twitter, that we should be using to get our message across, and because everyone else looks at it.
Well, in fact, I think we are using it in Africa and Asia more than we're using it in the U.S., quite honestly, around getting to the pot. I think that's an excellent question. I'm going to say let's also talk some more about that after the panel formally closes, because there's a lot of answers, or at least opportunities for some feedback to that question. So thank you for that. I think there was another, yes.
Thank you. I'm Kassar Mukhtar, and I have a question for Matt. Thinking about how childhood obesity is no longer sexy, I was thinking there are a lot of other things that have been normalized, and we sort of accept it. So while, in order for us to accomplish what we are discussing today, each level of the socio-ecological model, they have to do their part, right? It has to be a coordinated effort. But we've focused a lot on individual, families, healthcare. But I would like to think a little bit about the policy and the system level. So, Matt, how do we convince our decision makers, our policy makers, that there's certain things that should not be bargained for money, for financial, political benefits, and they should be left alone? For example, the food that we provide our children in school, I don't think any one of us would want to eat that food every day, yet we send our kids to school where, their health is affected, they're no longer safe, and we elect the political officials, right? There should be some understanding that there's some basic rights and there's some, anyway, so any answer to that question?
Yeah, no, I think that's a great question. And I think it's, when you think about let's take the specific example that you provided of schools, and I think, what I'd want to do, and I don't have the answer to this right now, is map out how that decision gets made, right? And I think part of the reason that things like that are, like you said, sort of unacceptable, is because, the people who are making the decisions often just don't see it, right? So your kids are seeing the food, the parents might be seeing it, the school ladies are saying, but none of the people, they're not necessarily the people who are controlling the budget, right? That's all happening at a different level. I don't know how it works in Georgia, but in Massachusetts, it's really hard to raise property taxes on houses, which are what you use to fund schools. And so that's something that gets cut. And it's not that anyone ever said, aha, let's underfund schools, let's underfund school lunch. It's that, these are decisions that everybody just let aside and didn't feel personally responsible, didn't feel like they were the actor that made that happen. So I think that's part of it is trying to figure out, actually map out those decisions. But then, to the extent that you can find those decision makers, make that stuff apparent and salient to them. So I'll give an example from some of the work that I'm doing right now in assisted housing communities, where they're going and asking us, how can you use behavioral science to get people to clean up and stop littering so much? And they want us to kind of say, use behavioral science magic. And I went and I interviewed people, and the reason that people are littering is because there's no trash cans anywhere. And it's been really kind of funny because I'm basically now doing I'm used to doing sexy, fun behavioral interventions, and one of the interventions I'm running is we should install trash cans in this community so that people can throw trash out. And it's such an obvious solution, and I don't think anyone sort of knew it, but it was really fascinating when I was interviewing people being they would have this big sign saying, "Don't throw the trash out there," and then everyone threw the trash out. And I would go to the custodial workers, I would go to the administrative staff and say, "Where are people supposed to throw out trash?" And they'd say, "Oh, there's the tiny little holes in their big apartment buildings that were, made in 1948. And I'm like, "Okay, but what if you have trash that's more than 16 inches wide?" They're like, "Oh, well, you have to walk 3 blocks and put it in a dumpster." I'm like, no one is ever going to do that. And just, sort of going back to your question, there's this idea oh, these people are, they don't care about their environment, they're willing to litter, and, can you use behavioral science for that? And I'm like, no, these people live in a system that is poorly designed for them. And so trying to go and ask those sorts of questions and figure out, how can we make those decisions, I think that's got to be part of it.
It's sort of meeting, this earlier comment, meeting the community where they are as well and what they need. So thanks for this. I suspect there's some more questions, but I'm going to ask the panel to give their 1 minute max take home for you all. And we are glad to stay longer. If folks have burning questions that you didn't get to, we'll be hanging around to have those discussions. So 1 minute rapid round, starting that in. Maria.
Oh, I think this has been really useful for me today to hear everyone's perspectives as well as to kind of at least hear a few questions from you all. I will say that, we didn't really touch on this today, but a lot of my work has been in looking at evaluating food assistance programs, and I think they were traditionally developed to address hunger and food insecurity, but now we really need to make that switch to how they can kind of address some of childhood obesity or some of the other access to healthy, affordable foods. And I think coming up with, my focus is always on evaluation and research, but, as well as coming up with the data from, making these kinds of programmatic changes, and then what from the data we can actually use that will help to influence decision makers, show why it's important to them within their district, show why it's important for their communities. So, I think that's sort of my quick 1 minute take home.
Does the 1 minute include the time to turn the mic green? So I think, just going back to this point, innovations for change. And I think, there's so much out there that we can be doing. And I think part of this is, and it's interesting some of the themes that we talked about today. I was talking about the behavioral stuff. We were talking about lots of ways that roll technology, but also that we talked about at the very end there, trash cans. And I think, we can get really, we should all continue to be excited about the new things. We should be excited about, how we can do this. But I think we should also be sort of aware both of these are hard problems to solve, but also that they're solvable. And there's low-hanging fruit, there's high-hanging fruit, and there's a lot of different strategies we can use.
You inferred, you didn't call it out, but again, by talking about the trash as well, it's multi-sectoral, right?
Yeah.
And I think
completely.
we need to keep that in mind. Christy.
So I think for global entities, the time to act is now. A lot of countries are transitioning, right, from infectious disease oriented to now chronic diseases. So, and it's not fair for them. Everyone has to die, but they don't have to die in the most productive years of their lives. And I think the most important take-home message for NCDs globally is that if we want to do chronic diseases in these low and middle income countries, because it undermines the work that we're doing in the infectious disease world. If they're not dying from malaria or HIV or maternal child health, they're going to die from a hypertension or from a heart attack. And I think it's important to collect data and use that data and to inform our decision makers. and leverage partners, traditional and non-traditional partners, to get that done.
Thank you.
I have 4 points. One, I think that we have many, many children, youth and adults who are undernourished and overcaloried. And I think we have to figure out how we get to the issue of overcaloried. I think that zip code is determining health not only in the United States, but many of our developed countries. And in our work with the Atlanta Regional Collaborative Health Improvement, ARCHI, our focus is on zip code and access to care. And in that process of working with those communities, we've learned that they're worried about lights on and a roof over their head, not necessarily whether they're going to get a chronic disease. And so we're working with what they want, which is food insecurity and getting kids to third grade reading level. We're starting with what they want, and then we'll build from there. My third point is don't start from scratch. Millions and millions of dollars have been spent on creating evidence-based programs, from Shape Up Somerville with Christine Economos to Spark with Jim Salas to DPP. And so many people are still starting from scratch. And when we were doing Take 10 work, it translated to Cheer 10 in Brazil and Happy 10 in China. The concepts are there. I hope that we take what we know and translate them into what works for that system. And that leads me to my final point, which is sometimes you have to start with system fit before you get to system change. And often we're trying to change an education system, a faith system, a community system, and we need to help them fit what works for them and then get to change when they're ready for it. Thanks.
Thank you. And I'm going to just add a point to that, is that it's not a zero-sum game. It's not infectious diseases and not chronic diseases or vice versa. And there's actually quite a lot of relationship between them, with diabetes and TB and so forth. But along with that, I would say to all of us, we can't afford not to address these issues. And making that economic case, if you will, not just in terms of the return on value for a package of interventions, but basically the larger economic ramifications at every country and every community level if we don't take this on front and center. So I think those are excellent summaries. I was writing down some very catchy, important phrases for us all to take home and cogitate upon, and I'd like to turn it back to Cindy at this point.
There we go. You have to wait for green, don't you?
Yeah.
Well, what a great discussion, everybody. I would like to give a round of applause to our wonderful speakers. Yes. You guys did a great job, and I think it was a fabulous discussion. As Diane has mentioned a couple of times before, I think we're kind of running up against time, so we need to go ahead and end. But if you want to mingle a little bit, ask a few questions, we've already talked with the panelists. They'd be happy to stay and answer some questions for you. But thank you all very much for joining us. Thank you for the great questions and participation as well. Thank you.